And here we go. So welcome to the ASQ Innovation Division Technical Community June meeting of 2024. And tonight we are having a wonderful presentation with Miss Katie Castri-Benyo. Join me in welcoming Katie, and you are in for a treat because she's going to be talking about utilizing innovation strategies to unlock cost-saving potential in clinical laboratories. Katie is a client account lead at Acumen. Primarily, she has a deep capability set as well as a wonderful thought leadership focus areas. So not only does she work in commercial and Acumen in the lab excellence service line, she really covers the spectrum of quality, innovation, and excellence. And you can see from the slide on the screen tonight, really focus on driving fiscal responsibility as well as operational efficiencies. She has a wonderful background in community health, both from her bachelor's and her master's, and she is an ASQ certified Six Sigma Black Belt and a Team Steps Master Trainer through AHRQ. She also holds a certificate in laboratory quality management systems. So again, she is a published thought leader, Value in Health, the Journal of the International Society of Pharmacoeconomics and Outcomes Research, as well as ASQ's Lean and Six Sigma Review. We'd like to welcome tonight to our ASQ Innovation Technical Community stage, Miss Katie Castri-Benyo. Thank you, Katie, and over to you, ma'am.
Thank you. And I can add to that publication list Quality Progress, the flagship publication from ASQ. In fact, a subcommittee of the healthcare division called the HQuick got our article published this month in Quality Progress. It's about quality partners, and it talks about the lab as well as healthcare overall. So feel free to check it out. Let me share my screen so that you can see the slides. And Rhonda, if you could just confirm whenever you see that.
Yes, absolutely perfect, Katie. Thank you.
All right, great. So as Rhonda said, this presentation is on using innovation to unlock cost savings within clinical labs. I developed a few learning objectives for the session. First, we're going to spend some time talking about the decline in reimbursements for clinical lab. If you're not too familiar with the industry, this is important to understand because this is really the backdrop that is the reason why we have to prioritize cost savings within lab, of course, while maintaining quality patient care. Then we're going to give an overview of innovation management and its principles, along with its relation to the ISO 56000 standards. And then we'll get into the real meat of the presentation, identifying the top 4 costs within the lab and exploring how innovation strategies can improve on those areas. Rhonda gave a little bit of an introduction, so I won't speak a ton on this slide, but we'll leave it there for a moment for your reference. I have always been in the healthcare industry within various roles, and she already covered some of my qualifications. I'm also very active with ASQ and have been over the years, and have really appreciated the opportunities that it provides for publication, for giving presentations, and of course networking and the different resources that I can use to learn and expand my tool belt. For those who might not be in the clinical lab industry, or maybe not even in healthcare at all, I wanted to first give just a quick summary of what a clinical lab even is. Healthcare facilities typically have labs to provide a pretty wide range of services, but they all aim around helping clinicians with diagnosing, treating, and managing patients. Labs are staffed by medical lab scientists who have been trained to perform these lab tests, which analyze samples of specimens that have been collected from patients. In addition to the medical lab scientists, labs would typically employ phlebotomists, which are those who collect the blood, lab assistants, histotechs, and pathologists, who are physicians, and of course, lab managers and directors to lead the department. Most labs are situated either within or at least near a hospital facility because they want to provide great access to clinicians and the patients that they serve. Now, the healthcare clinical lab industry is significant in size. Healthcare systems in our country perform about 13 billion tests per year. So as I said, I want to start with a little bit of a background on clinical lab reimbursement decline. In 2014, Congress passed something called PAMA, or the Protecting Access to Medicare Act, which reformed Medicare's clinical lab fee schedule to a single national fee schedule. And it was supposed to be based on private market data from all types of labs that serve Medicare. That would include independent labs, hospital outreach labs, physician office labs. And they did their first round of data collection in 2017, but unfortunately they failed to capture an adequate and representative sample of private market data. They virtually left out all hospital outreach labs, and they also significantly undersampled physician office labs. So this led to them using the lowest private market rates from large commercial labs, names that you've probably heard, folks like Quest, LabCorp, Sonic, who have some economies of scale that hospital labs just don't have, and used that data to set Medicare rates. Now, I want to point out that PAMA only impacts outpatient fee-for-service billing. Inpatient billing continues to be based on DRG systems, and so it is not impacting all of the lab's revenue, but a very significant portion of it. Over 2018 to 2020, the PAMA-related cuts to the fee schedule took place. Most common lab tests received sequential 10% cuts, which equates to an unprecedented 30% cut in payment rates over that 3-year period, which was about $4 billion in cuts to labs. Now, while this was only for Medicare, Medicaid and other national and regional health insurers tend to follow whatever Medicare does, so they reduced their reimbursement rates as well. A lot of the lab-related groups, College of American Pathologists, or CAP, submitted their comments to CMS and urged them to make some changes to the methodology to make sure that it would include all segments of the industry and thereby more accurate rates. Now, I don't need to remind you all what also happened in 2020, of course, the COVID-19 pandemic, which put an unprecedented demand for healthcare services on our employers within healthcare and their workers. There was a huge increase in the send out section of the lab for the COVID-19 testing. But outside of COVID testing, there was otherwise a net decrease in overall demand for lab services. And so cash flow at the nation's labs crashed. Revenues were down by billions of dollars within a matter of months. Routine specimens coming in declined by about 50 to 60%, and lab revenues fell by a similar percentage. Now, those labs who were performing COVID-19 testing got revenue from that, which would help offset some of that revenue loss, but that was really only about 20% of the pre-pandemic revenue that they needed to make up for. And a lot of labs were also unable to perform the COVID-19 testing themselves. In some cases, they didn't have the manpower or the expertise or the equipment. In other cases, there were significant supplies shortages during the pandemic that prevented some labs from performing that testing. You may have heard about that on the news. Now, Congress has intervened 4 times to delay the reporting periods for PAMA and 3 times to delay cuts related to PAMA. In 2022, there was actually a lawsuit around this. Back in 2017, the ACLA had filed this lawsuit against the Department of HHS about PAMA. And in 2022, the U.S. Court of Appeals ruled in favor of the ACLA and agreed that the PAMA regulations were arbitrary and capricious. And yet in 2024, we were supposed to have cuts of about 15% for 800 additional lab tests under Medicare's fee schedule on January 1st, 2024. Now, the House of Representatives did pass a 1-year delay of these PAMA cuts back in November. And so come January 1st of 2025, we'll see if those additional cuts take place, or if there are any efforts to either delay or change those plans. So here we are today. We really need Congress to pass legislation that would improve how data is collected and validated for PAMA. I'm sure that you on this call as quality practitioners can understand how important it is to have accurate data collected that would have a statistically valid sampling from all lab segments. There is an act called SALSA, or Saving Access to Lab Services, which would give CMS authority to recollect the data in a more appropriate way where the previous data collection had been inadequate. It also includes some other things like a reduction in reporting burden and a more gradual phased-in approach. And so this act is supported by many of the healthcare and lab-related groups. So thanks for bearing with me through that. Again, that industry backdrop is important to understand because it's that reduction in reimbursement that really forces us to focus more on the cost side of things within the lab. Next, we're going to give an overview of innovation management and its principles, as well as its relation to the ISO 56000 standards. Innovation management involves the process of managing an organization's innovation procedure, starting at the initial stage of ideation through the final stage of successful implementation. It encompasses the decisions, activities, and practices of devising and implementing an innovation strategy. Innovation management can also be defined as a business discipline that aims to drive a sustainable innovation process or culture within an organization. Often these innovation management initiatives use a disruptive method of change to transform business. And especially now with digital transformation, organizations are really faced with the need to innovate more and to innovate more quickly. Innovation drives business growth and helps organizations stay ahead of their competitors. It also helps generate new business models, creates new products and services and technologies for a changing market. And if it's done right, proper innovation management can also boost customer satisfaction and employee engagement. There are several innovation management methods. Broadly speaking, innovation can be incremental, breakthrough, or disruptive. Incremental would be where businesses are constantly reinventing themselves and they are just improving on their current products, services, processes, or methods. Breakthrough innovation would refer to a technology advancement that can boost the level of a product or service, again, still within an existing category, but something that can put you ahead of your competitors. And then disruptive would be an idea that's capable of radically changing the market behavior after it's implemented. So I was trying to think of a simple example to explain the difference between these three. And the idea I came up with was a taxi cab company. So incremental would be things like optimizing fuel efficiency, routes to avoid traffic and construction, maybe increasing marketing, going to highest need areas, offering training for drivers on customer satisfaction, optimizing your pricing structure or your hours of operation or the areas that you serve. All of that could bring great improvement to the company, but would still be considered incremental. Breakthrough would be something like giving the drivers GPS technology, which would boost your service. And then disruptive would be something like the Uber mobile app, right? That completely changed the market for customers and for organizations who compete in that space. For innovation management to be successful, it's essential that the company supports an innovation culture and makes employees feel valued. This will discourage employees from being afraid to generate ideas and allow people to be much more open-minded in generating quality ideas. Organizations can also leverage collaboration to get feedback. This would help you to generate a steady stream of ideas as well from stakeholders, both within and outside of the company. Another point for success in innovation would be to make sure that innovation management is a routine part of the business by following a disciplined and cyclical approach. This would include starting with ideation, the first step to innovation. You would want to incentivize employees giving feedback, again, trying to get that steady flow of ideas. The next step in a well-managed innovation process would be identifying the most valuable or viable ideas from that list. Companies can then move forward to create prototypes based on the short list ideas and then implement them to see how they work. And then the final step toward full implementation, it's really important to evaluate the outcomes of that to see whether the desired business goals were actually met once the ideas were implemented. A couple more keys to success. It's also necessary to engage the C-suite in discussions around innovation management to make sure that the ideas that are generated are in line with the organization's business goals. And then lastly, we're seeing a lot more today that organizations are increasingly looking for innovation managers. These are people who are equipped with specific leadership skills to drive innovation and to oversee that innovation management process. All right, next, what is the ISO 56000 series? This is an international standard for innovation management. It was published by ISO, the International Organization for Standardization, in 2020. It provides guidelines for organizations of all sizes and types to effectively manage and create a culture of innovation. And it covers areas like developing innovation strategies, the management of innovation processes, and the measurement and evaluation of innovation performance. Now, the purpose of ISO 56000 is to help organizations optimize their innovation efforts, but also to increase their competitiveness and to allow them to achieve sustainable success. Some of the benefits of adhering to the ISO 56000 standards, following them can bring several. Some of them are listed on the slide here. One would be improved competitiveness. By following the guidelines and the best practices that are outlined, your company can increase its competitiveness by developing more innovative products and services and processes. Another would be better innovation management because it provides a really structured approach to innovation management that can help the company more effectively manage its innovation efforts. This can lead to better decision-making, more efficient use of resources, and improved results. Increased efficiency would be another benefit. The standard provides some guidelines for managing the innovation process from ideation all the way through commercialization. And so this can help your company to streamline its innovation efforts, reducing the time and cost that's associated with bringing those new ideas to market. You may see increased stakeholder engagement because following the standard, your team can engage with stakeholders more effectively, including not just employees, but also customers and other partners. This would lead to increased collaboration and a more productive innovation culture across the company. And then lastly, one that people may not think about, it enhances your credibility and reputation because companies who follow this standard are really demonstrating their commitment to innovation and their commitment to best practices. This can increase credibility and reputation and make it easier to attract investment, to attract partners, employees, and of course, customers. Now, one thing that I really like about the standard is that it uses the PDCA cycle as the framework for innovation. As someone who is primarily trained in Lean Six Sigma. Of course, PDCA is something I'm very familiar with. And as I started to get more interested in innovation and especially how it might be applied within the clinical lab setting, I liked seeing something familiar and something that I know is effective. ISO 56002 is designed to work with the PDCA cycle, or the Plan, Do, Check, Act cycle, which, if you're not familiar, is a continuous improvement model. It's widely used in quality management and other fields. It gives a framework for organizations to continuously improve their processes and products by making small incremental changes. And in the context of innovation management, the PDA cycle can be applied as well. In the plan step, you would have the organization identify the innovation opportunity that they want to pursue and develop a plan for how to achieve that goal. The standard does provide some guidelines on developing an innovation strategy, which is a key component of the planning phase. In the do phase, organizations implement the innovation plan by launching the new product or service or process. They would also collect data and feedback from customers, stakeholders, other sources to inform their ongoing innovation efforts. After implementation, then it's time to evaluate the results of the innovation effort and compare those to your goals. So in this check phase, the organization would review that as well as the innovation process itself to identify any areas for improvement. The standard does provide some guidelines for measuring and evaluating innovation performance, which is an important component of the check phase. And then finally, an organization can use those insights that they gained from the check phase to make improvements to their innovation process as well as the specific innovation strategy. They can implement those changes to the product or service based on the customer and stakeholder feedback and other insights that they had gathered. And by following this PDCA cycle, organizations can continuously improve their innovation efforts and see better results. The standard helps provide some additional guidance and best practices to help organizations optimize their innovation management and to achieve their goals. All right, so we understand the history of clinical lab reimbursement decline and why we need to target lab costs for reduction. While we have little control over the revenue side, we need to focus on the cost side. And we understand these philosophies of innovation management. So how then do we apply them to improve? This will include the 4 top costs within the clinical lab, which are the testing itself, lab labor, lab equipment and supplies, and I would put reference testing in that bucket as well, and blood products. In alignment with the principle of realization of value within innovation, we're going to look at how these 4 critical areas can benefit from innovation approaches. Value realization is kind of the actual benefit where the true worth of a project or initiative is recognized. It's not just merely launching a project, but it really focuses on, are you fulfilling the projected advantages? Is it aligned with your organization's goals and with your strategic vision? All right, so the first area we'll look at is the lab testing itself as a cost. The demand for lab services is increasing, but much money is spent on tests and procedures that do not improve clinical outcomes. And inappropriate tests encompass the bulk of waste within medical spending. Specifically, a number of studies and reviews of insurance claims reveal that about 10 to 30% of lab tests performed in the US are either unnecessary or inappropriate. There is no correlation between volume or cost of ordered tests and quality of care, and there's wide variation in lab test ordering practices among providers. The cost of lab testing can be minimized through a lab stewardship program. If you're not familiar with this opportunity, lab stewardship is the careful, responsible, and evidence-based management of lab resources by reducing clinically unnecessary lab testing. A methodical lab stewardship program will increase lab capacity, reduce lab expenses, and maximize hospital profitability. It also, of course, improves patient care, which is probably the key driver. Correct patient testing improves diagnosis, and lab stewardship also reduces blood collection, which is a great thing as a patient. Experts agree that lab stewardship programs have 4 basic elements. Those would be governance, interventions, data extraction and monitoring, and review of that data coupled with the strategies and tactics for improvement. Now, we don't have time this evening to focus on all 4 of those areas. So for an audience of quality practitioners, I thought perhaps it might be of interest to focus on the metrics and analytics portion of that. Some of the key test categories that you would want to look at within a lab stewardship program would be testing that is occurring daily, genetic testing, high cost testing, what we call limited clinical utility, molecular testing is a huge area, obsolete tests, repeat tests, and any tests that are ordered in high volume. Now, within each of those categories, you'll want to identify not only the number of outlier tests, but also what percentage do they make up of all ordered tests? What is the cost of that testing in terms of dollars? And how does that trend over time? It would be ideal to have detail by facility, by specialty, by even ordering provider in many cases, by patient type or by patient location. And pictured at the bottom of the slide are just a couple of analytics dashboards that we use with our clients to look at these areas. Now, I do want to note just one more thing on lab stewardship before I move on. It's also about ensuring that the correct testing methodology is taking place as much as it is about reducing testing. We want to make sure that the patient receives the correct test. It's not strictly about removing tests, but if there are things that are recommended that you move away from in a certain setting, or if there's a very inferior test compared to another, which may often actually cost more money, then we'll look at those opportunities. Sometimes the better test does actually cost more, and in that case, we would want to go with whatever is better for the patient. The next opportunity we'll look at is lab labor. This is the biggest expense for most clinical labs. According to a recent survey, lab expenses make up over 60% of the total operating budget of a clinical lab. That's not just salaries, but would include benefits as well. And so labor costs can significantly impact the profitability of a lab and the hospital organization as a whole. So it's really crucial to understand and manage this expense. Now, today there is actually a shortage of qualified medical lab scientists. This increases costs because a lot of organizations resort to using expensive agency or traveling staff. Turnover is also very expensive because of the training associated with working in the lab, and overall just wage competition between you and your competitors as you're all fighting for the same scarce labor resources. So for this reason, it's really important to not only have continuous improvement in place, something like Lean or Six Sigma or any other methodology, to make best use of your current staff, but also to make sure that you then capitalize on the time and labor savings of that process improvement. And so the opportunity here to do this, labor optimization, is a long-term initiative to right-size the labor pool to the amount of work that's needed to support the business. And this is something that can be done not just in the lab, but really in any organization or industry. As your organization pursues continuous improvement, again, whether it's through Lean, Six Sigma, or any other methodology, in theory, successful projects are going to reduce the workload. And then the labor pool can shrink over time while you're still maintaining or even improving quality and service standards. If your organization is seeing an increase in the volume of service that you provide, or you'd like to pursue one, then right sizing might look like maintaining the current labor pool while growing the business. If volumes or business are stagnant, then right sizing can be achieved through attrition, not a reduction in force. And there are 4 key components to successful labor optimization. Those would be continuous improvement, of course, as number 1, but then establishing labor oversight, data analytics, and countermetrics. Again, not having time to focus on all of those keys to success for this single opportunity this evening, I thought I would focus on the metrics and analytics portion of that. So what are some of the things that you would want to consider? First, of course, you need volumes of units of service provided, or in our case, the number of lab tests performed and billed. Then labor in terms of hours or FTEs. Use those to calculate a productivity metric in terms of units per hour or hours per unit, whichever you prefer. So in our case, lab tests performed per worked hour. Labor cost in terms of dollars, and then again, the calculation of those two, labor cost per unit. So in our case, lab labor cost per test performed. And I know they're pretty small on the slide, but there are just a few of the analytic dashboards that look at these metrics. All right, the next cost opportunity we'll look at in the lab is equipment and supplies. The supply chain for the lab is seeing really rising costs at healthcare systems across the country. The average hospital supply cost increase overall over 2019 to 2022 was 18.5%. Perhaps that number doesn't mean much to you, but that is outpacing inflation by nearly 30%. Perhaps that helps to put it in perspective a little bit. And lab services specifically saw an increase of 27% over the same time frame. So there's great opportunity to reduce costs, even while improving performance of lab equipment and supplies. But there are several challenges in this area. Hospitals and labs might not have a dedicated team of experts who focus on the lab. It's a very small department in the grand scheme of the hospital. Typically, the renegotiation of a contract would only occur every few years. So even a more tenured lab leader might have only gone through this process a few times in their career. Another opportunity is that any clinical changes have to be, or I should say another challenge rather, is that any clinical changes have to be very carefully considered. You have to have buy-in from clinicians if you're recommending any kind of a change in a product. With robust market data and lab product and vendor knowledge, there is opportunity for a lot of cost savings in the lab supply chain. Another area that I would also lump into this bucket would be reference testing cost. And what I mean by that is if there are tests that a lab does not perform in-house, then they will send them out to a reference lab, someone like Quest or LabCorp or Mayo Clinic, ARUP, and that's an opportunity for cost reduction as well. There are several areas for you to consider here. One would be to benchmark data of reference testing cost and make sure that you're getting appropriate pricing. Another opportunity would be to consolidate your send out volumes. If you are sending them out to multiple reference labs, then you're not really taking advantage of higher volumes equating to lower pricing. There's also the question of insourcing or outsourcing at all, the make versus buy question. You may be performing something that you should actually be sending out and could do cheaper that way, or vice versa. You might be sending something out that you could actually do in-house for less cost. All of these decisions need to be made on a lot of data and looking specifically at the demand for testing, the capacity that you have in your facility, both with staff as well as with equipment capacity. Now, the metrics and analytics discussion for this area looks a little bit different. Basically, a lot of benchmarking is involved when looking at the supply chain for lab. You would want to look at all categories. You can cross-reference across sites of similar spend. You can cross-reference across vendors within the same category, but it's important to make sure that the market knowledge that you're using on pricing is real time, because as we saw in the numbers around outpacing inflation, These things do change pretty quickly. Some of the key fields that you would want to collect are listed on the second bullet point there. I won't read those to you. And then some of the key questions that you would want to ask with these pieces of data or information are in the table at the bottom. For example, looking at total contract spend, the value of the contract can often drive some discounting based on the spend amount. When you look at the contract start and end date, if it had an earlier start date or is an older contract, then it's likely somewhat out of date per the benchmarking today and lower pricing might be available. Looking at the contract end, a longer term typically means more revenue booked by the vendor and therefore you can get lower pricing. Commitment level, typically what you will actually put down on paper is only 80 to 90% of the actual spend because you don't want to fail to meet your commitment. But a higher commitment means lower pricing. So again, making sure that you're consolidating between vendors to achieve that. And then some additional points there. I won't read the whole thing to you, but about equipment acquisition. And GPOs are the last one called out here. Often by getting a local agreement, you can actually improve on the price, the best price through the GPO. So it's important to consider both options. Now, supply chain management is more than just benchmarking. While I say that, it is really important to look at the category holistically and to make sure that you're creating value for the lab, for providers, and for their patients, and looking at more than just the pricing. All right, the last opportunity of the 4, and this one is pretty interesting if you're not familiar with this area. I'll start with a few statistics for you. This one is looking at blood products, and a blood transfusion occurs in the US every 2 seconds. In patients over the age of 64, it's the second most common procedure performed in US hospitals. And for patients in a slightly younger age group, it's the 5th most common. But overall, transfusion of blood and blood products happens in 3 to 5% of hospital stays, depending on patient age group. Now, due to recent shortages of blood products, as well as increases in blood product pricing, a lot of hospitals and healthcare systems are looking for ways to reduce their blood product spend. Maybe you've heard about some of these shortages of blood products on the news. The pricing, while it's quite different from the supply chain conversation that I just shared, you really do not have a lot of room for negotiation on blood product pricing because, as I said, it's a scarce resource and the pricing kind of is what it is. So the opportunity here is actually that, similar to the idea behind lab stewardship, the best way to minimize blood product costs is to instead focus on appropriate utilization of blood products themselves. Now, we have a lot of perceptions about blood transfusion, especially here in the US, among both clinicians and the public. We tend to think that blood transfusions are rare, their safety is high, their risk is low, they contribute positively to patient outcomes. But in reality, transfusions are very common, as you saw in the numbers there. They are in fact risky, they are costly, they are inconsistently available, and in many cases, they're either associated with poorer patient outcomes or at least ineffective for the purpose that they're given. A blood transfusion is truly a liquid organ transplant that's ordered by a physician and performed by a nurse, although we don't tend to think of it that way. And I know quality practitioners love a good histogram or normal distribution, so take a look at the chart. I know it's small, but in the bottom right there, for the typical 1 to 3 units of red blood cells that would be transfused, there's a bell curve. Few patients receiving transfusions do indeed have their lives saved. Many transfusions, however, have questionable or no benefit, which means that they are then mostly risk. And there are even a few patients who have experienced death from a blood transfusion. For many patients, transfusions only introduce risk and cost. And so the opportunity here is a patient blood management program. Typically, this would involve a multidisciplinary team of individuals And the idea is that we want to advance only the safe, effective, and optimal use of blood products through this quality improvement effort. PBM programs also now include a lot of promotion of preemptively managing a patient's anemia in order to avoid even the need for a transfusion. It's kind of interesting, the idea that we often talk about blood transfusion, which is a treatment, without talking about the disease. We would never do that in any other area. You would not talk about going and getting heart surgery without first trying to optimize your heart health. And yet a transfusion is often a Band-Aid that we go directly to without having any conversations about anemia. A successful PBM program would not only vastly reduce the lab's cost of blood products, but also, of course, significantly improve patient care. Here are the metrics and analytics that you would want to consider when implementing a PBM program. First is blood product utilization, of course. You would want to trend that over time, look at it by facility and by specialty, equate that utilization to cost in terms of dollars, but also to some of the clinical ramifications, risk or adverse outcomes that you may be incurring because of a transfusion. The more process metrics as opposed to outcome metrics are a little bit different for red blood cells versus platelets, which are two different blood products that would be transfused. For red blood cells, the current literature recommends that you look at the percentage of transfusions which use a single unit and then reevaluate the patient's hemoglobin before possibly transfusing a second unit. The percentage of units that were transfused with a hemoglobin less than 7 versus greater than or equal to 8, and the average pre-transfusion hemoglobin. For platelets, the literature recommends metrics that become a bit more complicated. Patients need to go into 3 different buckets based on their diagnosis, which would be pre-procedural, prophylactic, and then surgical therapeutic. And depending on which bucket they're in, the recommendations are slightly different. All right, I know that I have covered a lot, but in summary, lab reimbursement decline really necessitates us targeting lab costs. And so in line with innovation management's goals, these 4 areas of focus for the clinical lab can benefit from the application of these principles. Here are the takeaways for the session. I won't read them to you again, but hopefully you feel like we have indeed covered all 3 of these. And then before we take questions, I just want to note that my contact information is here. If you would like to reach out to hear more about these opportunities or to just give any feedback on the presentation, if you just want to connect on LinkedIn and keep in touch with what each other is working on, that is always welcome as well. So Rhonda, I'll turn it back to you to see if we have any questions in the chat.
Thank you so much, Katie. Yes, we do. We have the first question from John Lewis, and he says, when collecting data to determine the price schedule, wouldn't Medicare want to throw out outliers so that extremely overpriced or underpriced lab fees don't skew the data set?
Yes, they absolutely would want to. And there may have been some removal of outliers, but the bigger problem is really about collecting different lab segments. If you only collect information from the bucket of those very large labs who have economies of scale, Mayo, LabCorp, Quest, Sonic, then of course not including the bucket of physician office labs and hospital outreach labs, it's not an adequate representation of all labs. But yes, outliers as well.
Thank you, Katie. Let's see. The next question, also from John, is he can see where collecting genetic data might help find a future cure. But he wants to know if patients are charged for these genetic tests, even if it can't possibly help to cure their particular condition at this time?
That's a good question, and I'm not sure if I have the expertise to weigh in on that. It depends on whether you are getting this test directly from a lab, which is likely not the case. You're probably going through a third party, an insurer that you have, and they do have requirements for when insurance does or does not cover a lab test. Beyond that, that's really not an area of expertise for me, so I couldn't tell you much beyond that. Sorry.
No worries. Let's see. Okay. Trent Jansen wants to know, what sort of technology difficulties do you think labs are currently experiencing?
There is a lot of technology in the lab, more than you might think. Um, all throughout, I mean, for every phase of the lab testing process, in pre-analytical, when phlebotomists and nurses are collecting blood, technology is used, barcode scanning of a patient's armband, handheld devices that tell them which patients have draws to be collected. Once the sample makes its way to the lab, there may be an automation line that a non-technical staff member will put that sample on, and it'll carry the tube down the line, take the cap off, probably spin it down first in a centrifuge, depending on what test it is and what type of sample is needed, but carry it on down the line and load it on an analyzer. So there is technology being used, which helps a lot with, again, optimizing this really scarce labor resource that we're experiencing right now. And then even on down through resulting out the test. Equipment can auto-verify some testing without manual intervention of a medical lab scientist, especially if that result is a negative. It can pass through the process without being reviewed. If it is a huge delta from either the normal range for that test result or a huge delta from a patient's previous test result, then it's going to be reviewed by a medical lab scientist. And then in the area of pathology, there's a lot of technology as well. Digital pathology became much more desirable during the pandemic, so that if a pathologist doesn't feel comfortable coming into the hospital facility, they can still read slides from home. Glass slides can be digitized, and you can look in a microscope that's looking at a computer instead of looking at a glass slide. And there's even some artificial intelligence within pathology. AI can help pathologists who are physicians to, it kind of gives them the first guess of what it thinks it's looking at, which can make the process more efficient for a pathologist to review a sample and ultimately make a decision. So there is a lot of technology within the lab. The challenges there are sometimes it's not cost effective for particularly a small facility to be able to invest in some of this technology. That's probably the biggest challenge. If you've got the funding to be able to bring it in-house, then typically the training is not really the issue. Did that answer the question, I hope?
I believe so. I think Trent was adding on and saying, is there a step that is more frustrating than others because of the outdated technology?
Okay. I think the biggest area of opportunity workflow wise continues to be on the front end of the process, the pre-analytical phase of lab testing. Phlebotomists are a very low skill, low wage position. They have very high turnover, and so training is a challenge. You can make more money going to a fast food joint than you can working as a phlebotomist, where you're asked to come into the hospital and go draw patients, wake them up at 3, 4 o'clock in the morning to draw their blood so that those lab results can be available by the time physicians do their rounding at 6 or 7 a.m. And so it's a very challenging team to manage. And we tend to see a lot of errors on the front end of the process. Not mixing up patients' samples. Typically, that would be a pretty drastic error. That is kind of what people might think of as the mistake, but it's more things like things that require rework. If you label the sample, but your little things, your printer's out of ink and we can't now scan that barcode, that creates rework. You have to relabel it and start all over again. If the sample is sitting on a phlebotomist's cart for an hour of time because they don't use an efficient workflow to collect samples and send them down to the lab, that's a huge area that we work on improving. Then you get into specimen integrity questions. Samples that may be couriered from one location to the lab, specimen integrity may become an issue there as well. So it's definitely the front end of the process, and it's not necessarily technology related.
Thank you, Katie. Okay, Trent, so that answers his questions. Thank you very much. And others are saying, thanks, great job, Katie. Okay, we'll jump into a couple more questions since we still have a few moments with you. And how about, can you provide specific examples of how innovation management principles, particularly those aligned with ISO 56000 standards, have been successfully applied in clinical laboratories to achieve cost savings, like
yes,
a particular project, etc.?
Yeah, I'll share one project example just to give an illustration. I mentioned that the standard uses the PDCA framework, which I really appreciate. As I mentioned, the pre-analytic portion of lab testing is typically a huge opportunity to reduce error, yes, but also to become much more efficient. And what happens in traditional phlebotomy teams is that each one will be given their patients to draw or their units to draw, and they'll kind of part ways and go collect those areas very independently. That leads to a lot of opportunities for improvement. It's less efficient. If you're a new staff member who may be fresh out of training, you might get a hard stick patient and you don't have a more tenured colleague there to help you with that draw. If the patient is unable to be collected, what happens to that label? It gets sent back down to the lab, and maybe an hour later, someone else comes back, wakes the patient up again to try to draw their blood again. Phlebotomists may be going in and out of rooms with multiple patient labels on their person, which can increase the opportunity to mismatch patients. They tend to just walk room to room collecting and putting all of those samples on their cart. So it's a lot of batching. The sample may sit there on the cart for an hour while you finish collecting that entire unit, and then send them all down to the lab through the pneumatic tube system. So there's a lot of opportunities for improvement there. One thing that we often implement, we call it phlebotomy swarm. Some organizations call it phlebotomy sweeps, but it's a team approach to the inpatient morning run. And when I say inpatient morning run, if you have ever stayed in a hospital or had a loved one who did, you may know that blood samples are often collected at 3 or 4 o'clock in the morning so that they can get down to the lab and be processed and tested and have results when your physician is then rounding at maybe 6 or 7 in the morning. So we do a lot of focus on optimizing this inpatient morning run process. Under a phlebotomy swarm technique, the group would instead travel as a team, take turns taking, they have kind of an extra cart in the hallway to help them organize this process, take turns taking just one patient label at a time, go in the room, draw the patient, come back out and place it on that team cart, and kind of leapfrog around each other down the hallway. But every maybe 3 or 4 patients, as everybody goes into a room and then comes out, whoever is that 3rd or 4th person takes all of those samples and immediately tubes them down to the lab. So we get rid of that batching. We eliminate the opportunity for any specimen integrity issues, and that just impacts the efficiency of the process all the way on down the line. Because when you're down in the lab receiving at the pneumatic tube system, you wait, and then you get this huge pile of samples that comes down. It's very inefficient for you to work your way through that pile as well. And on down the line, next it goes down to the medical lab scientists who are loading instruments and resulting tests, and we see that batching all the way through. So if we streamline that process up front and move it more towards single piece flow, not single, but closer to single, then we see a lot of efficiencies on down the line. So that's, we kind of start at the beginning of the process and then work our way through with projects. So that's a typical one that we will often do first with a lab if it's an opportunity.
Thank you so much, Katie. We have another question come in from Daniel Ye. He says, do you see a future where clinical labs achieve significant quality improvement via augmented reality? For example, could you use Apple Vision Pro while receiving or testing specimens to identify any mislabeling or incorrect specimen types?
I'm not the most familiar with augmented reality, but I wouldn't say no. I mean, we probably never thought that artificial intelligence would be used within the lab, right? It is highly scientific. It takes much training for medical lab scientists and for pathologists to be able to do what they do. And it's a very respected position. We probably did not think that we would be seeing the use of technology in the lab that we do see today. So while I don't know a ton about it, I'd say might be very possible. Great question.
Thank you, Katie. We have one more from Mr. J. Lewis. Are you seeing more use of PFMEA in this industry?
FMEA in healthcare is interesting because when you go to rank the severity of an issue, in a sense, everything could lead to a patient dying, right? And so it's very hard when working with teams of clinical folks to rate the severity of potential problems because everything is severe. Everything could lead to a patient's death. And I don't mean to say that so lightheartedly. I mean, it's serious, but we have to be able to distinguish between lower severity and higher severity. And that tends to be somewhat challenging to do within healthcare.
Thank you, Katie. I think we have time for perhaps one last one.
Okay.
How can clinical laboratories balance the need for cost efficiencies with the imperative to maintain high quality patient care and accurate diagnostic outcomes?
Great question. It's definitely important to balance quality and service as well, meaning turnaround time, along with efficiency. Specifically, when we look at labor optimization, we want to make sure that as we minimize the labor that's required, we don't negatively impact quality. And that as we try to, slim down processes as much as possible, that we're maintaining that quality all throughout. So it absolutely needs to be a component that you consider. And when it comes to recommended metrics, we would also typically include, we call them counter metrics, but just tracking all of the quality and turnaround time KPIs, even as you're doing a project that's efficiency focused, to make sure that you maintain those throughout. And in many cases, they often improve hand in hand, right? Like the phlebotomy swarm example I gave as just one simple illustration. That's going to be more efficient and reduce labor and cost, but it also improves quality and turnaround time. So there are a lot of benefits, but absolutely with any project, you should be monitoring those to make sure that they're maintained.
Well, Miss Katie Castri-Benio, thank you. Let's give a big hand to our special guest speaker this evening for ASQ Innovation TC June 2024 session. And again, thank you so much for sharing your expertise and answering these phenomenal questions from our attendees. We have just one little bit of information before we let you go this evening, folks. And that's an invitation to join us in an upcoming session. So first and foremost, we wanted to share with you our ASQ Innovation Technical Community Officers, our chair, Miss Rebecca Mott, our secretary, Miss Jackie Jolly, and our immediate past chair and treasurer, Mr. Larry Miller. If you are liking what you're hearing tonight and want to learn more about the ASQ Innovation team, we invite you to reach out to Miss Rebecca Mott. Each and every one of you will get a copy of these slides where you can signal if you're interested in future volunteer opportunities and what that might look like for you. And then if you have not engaged in our My ASQ community, you'll get a link there so that you can, we had multiple questions come in from other leaders, so we will be seeing those in the discussion forums and then posting ways that you can follow up with Katie after tonight. If you're interested in the ASQE Insights on Excellence, we have some wonderful research that we can share with you. And if you're not a member of ASQ or ASQE, we'll send you a link for you to join. We invite you to join us on the 25th of July, the 22nd of August, and the 12th of September, where we have a phenomenal lineup for you with Miss Paula Schindel talking about navigating the future of IT service management, Miss Lashira Champion King talking about innovation includes you, and Ms. Rebecca Mott, who will talk about her experience with innovation across multiple industries. That's it for tonight. Again, we thank our wonderful guest speaker, Ms. Katie Castri-Benio, for her fantastic presentation tonight, utilizing innovative strategies to unlock cost savings potential in clinical laboratories. And again, we invite you back in a future session to join us on our next innovative journey. Good night, everybody. Have a happy 4th of July, and we look forward to serving you more at our July event. ASQ Innovation TC out today. Good night, everybody.